Today's session will be a very broad topic on what is focal therapy. As an introduction, we want to thank Wasatch Medical Specialties. They are the exclusive distributor for Galil prostate cryoablation products in the US. This is the agenda. As you can see, the purpose is to provide education for attendees. The target audience is for people engaged in the broad treatment of prostate conditions and prostate cancer. This is CME accredited. As one disclosure, some of the topics that you see, depending on where you reside in practice, may not be standard of care, but may be ideas and treatments in development. You will receive a survey from Michelle Paoli. Please indicate which seminars you have attended, and you will get your CME certificate. Please complete the evaluation questionnaire at the end of each seminar. There will be a Q&A function. You can submit your questions. Some of those questions will be responded to in writing. And what we'll try to do is save the questions for the last 5 to 10 minutes of the program and answer some of the more broader questions at that time. All upcoming webinars are listed on the Endourology website as shown there. So today's session is What is Focal Therapy? I'd like to first introduce our moderator, Dr. Eric Beret. His photo is on the right. He is a urological surgeon at Montsouris in Paris. He's a recognized expert in minimally invasive technologies. He coined the term a la carte approach. He has extensive experience in robotics, HIFU, cryotherapy, and vascular targeted photodynamic therapy, along with irreversible electroporation. In addition to these clinical activities, he is the chair of the ablative group of the EAU section of Urotechnology and is involved with ongoing collaborations with urological oncology. I'd like to introduce Dr. Beret, who will then run the program.
Hello, thank you, Tom. Thank you for this kind introduction. Thank you for the invitation. So I'm very happy to share this session with you. The masterclass will be divided into 4 parts. We will have 3 very interesting talks of 15 minutes each and 15 minutes for discussion. So the talk will be given by 3 great experts, and they will cover 3 topics. First, the definitions and the ablation template. The second is the status of the untreated prostate parenchyma after focal therapy, and the third one is the quality of life in the patient with using the prompts after focal therapy. So let me introduce the first speaker. The first speaker is John Ward. John Ward is a professor of surgery in the Department of Urology at the MD Anderson Cancer Center at University of Texas, Houston. After fellowship in urologic oncology at the Mayo Clinic, Rochester, he returned to the US Navy to complete a career serving his country before joining the clinical faculty at the MD Anderson in 2006. He is a great expert in prostate cancer management and in focal therapy. He has authored multiple definitive manuscripts and book chapters that underpin the basis for prostate cancer focal therapy. John, it's yours.
Well, thank you very much for the nice introduction, and welcome to everybody who's joining us on this masterclass. I think just as when we went to medical school, we first had to learn how to talk the medical lingo, and that's important when you begin your focal therapy program. So we're going to go through some of the terminology and the templates we use in focal therapy. So focal therapy is really the individualized treatment that selectively ablates known disease and preserves existing functions with an overall objective of minimizing the lifetime morbidity without compromising the life expectancy. In other words, controlling the cancer without affecting any of the functionality. The early results from trials and prospective studies have supported the use of focal therapy as a potential standard of care option, but none of the available guidelines now include focal therapy because we lack the truly needed randomized controlled trials or even high quality data to really get these into the guidelines. So in order to get them into the guidelines, we have to have appropriate study of what we're doing with focal therapy. And there's various degrees of what is considered focal therapy. And that's what we're going to try to go over here, so that as each of you starts to do focal therapy and starts reporting on what you're doing with focal therapy, we can understand what partial gland ablation has occurred, so we can compare apples to apples. Because there are various means of performing focal therapy, it has the potential to complicate the comparison of the patient data. And as well, there's multiple ablative technologies that can be used for focal therapy that I won't get into in this talk, but that also has the possibility of complicating our comparisons of groups. So focal therapy definitions are important because we want to compare apples to apples. So we need to be using the same nomenclature, and that'll help support the development and dissemination of focal therapy. And societies such as the Focal Therapy Society and the Endourologic Society are spearheading efforts to normalize the language that we use to discuss this emerging field, and hopefully make it become part of the landscape for patients. Back about 10 years ago, Steve Jones and I recognized that we had a Tower of Babel in the way that we talked about focal therapy. And so we tried at that time to come up with definitions for definitions and terminology for focal therapy. And about 10 years later, once we really got organized as a society, we got an international coalition of experts together to really look over what we were doing for partial gland ablation and come up with our terminology that we now use to describe focal therapy. And we'll go through each of these terms as we go through the talk. Importantly, when you start talking about focal therapy and the use of templates for focal therapy, we come back to how we diagnose patients with prostate cancer. And a lot of prostate cancer and the biopsies that we performed depended on what you were going to do with the information that the biopsy provided. When all we had was whole gland treatments, it was just a matter of finding a focus of cancer within the prostate. And that was enough to provide some sort of justification for moving forward with the whole gland treatment. But as we go into focal therapy, it's not just finding that a patient has prostate cancer, but it's finding where the prostate cancer is and what the conformation and the configuration of the prostate cancer is that becomes important. And that's a much bigger challenge, but that also comes into how we go about using our templates for focal therapy. One of the other things you have to consider when you're doing focal therapy is what your understanding of the biology of prostate cancer is, and whether or not you agree that all tumors have to be eradicated, all tumors that are within the prostate have to be eradicated in order to have good oncologic efficacy, or if you can really buy into the index tumor theory, where only the most aggressive of tumors have to be ablated or treated, and the remainder of the multifocality of prostate cancer is not used or is not treated. So no matter how much you do a biopsy, I'm going to go through this real fast. No matter how many biopsies you do, whether it's a saturation biopsy, you have to remember that you're only sampling a very small portion of the prostate. And you can go through, as we did here, to look at what percentage of the prostate you're actually examining when you do a 100-gram prostate, and you come down to a very small volume of the prostate. So again, the information that you get from a biopsy, you have to use carefully when deciding on your template for focal therapy. And performing the biopsy is also hindered by such things as the moving target of the prostate moving every time a patient breathes, the swelling and the capsule deformation, and even the deflection of the needle tip towards the target that you're trying to get. We also know that the person who is doing the biopsy can be an independent predictor of whether or not the biopsy is positive. In this study by Lawrence Chuck, he found that there was between a 0.67 and 0.89 odds ratio, depending on which of the 4 biopsy physicians was performing the biopsy sample itself. So all of this has to come into play whenever you're considering what you're going to use for your focal therapy template, because inaccurate information can lead you to the wrong conclusions. So which treatment templates? So you have to choose a treatment template that is commensurate with the sensitivity and the specificity achieved with the biopsy, given all that I just discussed with the biopsy, the limitations of the biopsy. You have to choose a template that achieves the oncologic goal that you believe that is important for the patient. And you have to choose a template that the precision of the energy can actually deliver. Some of the energy sources that are available for focal therapy actually have a very broad distribution versus a very narrow distribution. So all of these should be considered whenever you're looking at the templates. The templates in detail, you have true targeted focal therapy, where you try to identify every tumor throughout the prostate, oftentimes through some form of saturation biopsy, and then try to be able to get back to each of those locations to provide a very precise, focused ablation of those tumors. As I say here, it requires precise and reproducible localization of the cancer. So it's not just that you find every cancer, but that you also have to be able to get back to that spot once you come to your ablation energy. It does maximally preserve the prostate tissue, but cancers, you have to remember, are irregularly shaped. We like to draw this axial view of the prostate that you see on your screen here, but in actuality, the prostate tumors extend into your screen and back towards yourself and are oftentimes three-dimensional in shape. And you have the question of safety margins. You know, how much, if you identify a tumor here through a biopsy, how much of a margin around it do you have to include in your ablative pattern? And the precision of the energy, something like cryoablation is going to have a much larger field effect than something like a laser ablation. And how you visualize the tumor during the ablation. Some of these tumors you're able to pick up through biopsy, but you don't necessarily see them. And so you have to be able to have some way, or consider at least, what you're going to do to visualize the tumor area. You then move into quadrant or zonal ablations of the prostate. This includes a larger volume of normal tissue within an area that's identified to have the cancer. There's a greater safety margin, essentially. And as you start talking about your quadrant ablations, you have to include whether it's an anterior or a posterior ablation, whether it's towards the base or the apex of the prostate, and whether it's on the right or the left side, because all of these might come into play in our understanding of your outcomes. You get into hemiablations of the prostate then. This is a lateral hemiablation, which again increases the volume of tissue that's destroyed, and thus includes some of the multifocality, at least on one side, that is associated with prostate cancer. When describing your focal therapy, again, you need to use modifiers like anterior or lateral and right or left. This would be an anterior hemiablation, in which again, there's an increased volume of tissue that is ablated. It covers both sides of the prostate and stays away from the neurovascular bundles. It accounts for a lot of multifocality that you can see up here. And again, you have to use modifiers, anterior, lateral, as I mentioned before. And then you have the hockey stick ablation, which is something that we first described whenever you have a dominant tumor over on one side that you can identify. We've actually found that oftentimes, through the way that we used to do biopsies, you would have contralaterally missed tumors. So we included this hockey stick pattern here. Again, modifiers are required, left dominant, right dominant, and there's even a posterior hockey stick that has been described using HIFU. This was how we came to that hockey stick technique. I'm going to go through this. And then we just recently published our trial with 23 patients that underwent hockey stick focal ablation. Of interest, we did have 8 patients that did have a positive biopsy. All of these patients had 3 biopsies following the hockey stick ablation. We had 8 patients that were positive, all of which were out of field positive biopsies. 6 of them were less than 1 millimeter of Gleason grade 1, so what we would consider insignificant, while 2 had Gleason grade 2 that we could, or grade group 2 that we could move on to additional focal therapy. And then we had very good functional outcomes from that. And then finally, there's subtotal ablation, which is the maximal partial gland ablation that could be considered focal therapy. It tries to maximally preserve the erectile nerve bundles on both sides of the prostate while accounting for the multifocality that you oftentimes see within prostate cancer. So in conclusion, Focal therapy implies the partial gland ablation using any of a number of different treatment templates that we just went over there. Template selection is based upon your reliability of the biopsy information, the understanding of prostate cancer biology, and the precision of the energy source that you use to affect your focal ablation. And it's important to use these standard nomenclatures that I just introduced to you, so that when you describe your results to the rest of the community, we can understand what has occurred and compare them to others, the outcomes from other trials. Thank you very much for your attention.
Thank you very much, John. So we are going to discuss at the end. So right now, let's move on to the next speaker, next talk on the patient selection with Massimo Valerio. Dr. Massimo Valerio is a staff urologist at the Centre Hospitalier Universitaire Vaudois in Lausanne, Switzerland, and he is associate researcher at the University of Lausanne. After finishing his residency in Lausanne, he obtaining a certificate in advanced studies in clinical research from the University of Lausanne. He joined the University College London group as research associate and achieved a PhD in this university in 2016. Massimo is a member of several society. He's a member of the EAU Young Academic Urologist, of the EORTC, of the ERAS, and he acts as editorial board member and reviewer for many peer-reviewed journals. So Massimo, it's yours.
Thank you, Eric, for your kind introduction. I didn't know that my bio will be all said. Thank you. So my talk will be about patient selection. And I think the previous speaker already highlighted how the patient selection is really the key to success in focal therapy. So I think it is really a key topic if you want to join the focal therapy community or if you're interested in focal therapy. So during my slides, I will go on, this is an overview of what I'm going to talk. And first of all, these are the characteristics you have to look for in an ideal patient who is candidate for focal therapy. I think the first one, it's needs to make sure he is a candidate for treatment, which means he needs treatment, the patient. Because one of the criticisms at the beginning in the focal therapy milieu was that focal therapists were treating a lot of men who would otherwise be in active surveillance. And say, maybe in the beginning was the case, but nowadays it's accepted that it's not the case. So the first thing is that the patient needs treatment. The other characteristics, it's about the disease and the patient, and I will go through this. First of all, I think there are some characteristics of the disease, but there are also some characteristics of the patient. And if I regret something in my focal therapy program is that sometimes the disease was amenable to focal therapy, but not the patient. I will talk about this later on. So who are the candidates for focal therapy when you see a patient coming to your office? So this is the a report from the PROMISE study. The PROMISE study was a validating study for MRI, in which consecutive men with a suspicion of prostate cancer based on PSA or on digital electroexamination had really state-of-the-art assessment, because they got at the same time a multiparametric MRI, a thrust biopsy, and a template mapping myopsy. We are talking about 596 men who never had a biopsy before, who had around 70 biopsy per patient. So obviously, it's not perfect, but I think apart from being a study about MRI, it's a study about prevalence. If you look at the results, you know how many men in your office are coming for a suspicion of cancer and how many you should find if you're good enough. Why good enough? Because MRI was blinded to the urologists. And so all men, irrespective by the MRI phenotype, they got a biopsy every 5 millimeters in the prostate. Once again, if someone had a volume of the prostate of 50 mils, he got 60 biopsy in all parts of the prostate through the perineum. So this is a kind of precision which can be achieved only by taking out the prostate. What did they find in this study? I'm not talking about the results of MRI, I'm talking about the results of the biopsy. So if you take consecutive biopsy naive men, and you do all of this, you have around 1/3 of patients, which are those in white, which have no cancer at all. So it should be discharged or follow-up, according to the PSA. You have another 1/3 of patients who have a Gleason 6, an IZIP1. So most of these men obviously should be on active surveillance. The other rough 1/3 of the men, they will have, most of them will have a Gleason 3+4. And another minority will have 4+3, and a really minority of biopsy naive men with a PSA less than 20, as was for the study, will have Gleason 8, 9, or 10. Now, who are the candidates for focal therapy? Once again, I think we should not overtreat and we should not undertreat. So you should not overtreat men who can be watched at the beginning, and men who are likely to have multifocal disease or will need multimodality. I think they should go for that. And this is suggested by the pathology study in radical prostatectomy specimens. So we are looking for these patients maybe more for the 3+4 and some men with 4+3, which are well characterized. Now, since long time, everyone agrees that in a prostate, there is a dominant lesion in which you have the highest volume and the highest grade. Obviously not in all cases, but in most cases. But the barrier to focal therapy has always been that you didn't have a means to know which was the area with cancer and which was the area with no significant cancer. And obviously, as Professor Wood said, if you have to treat one man with a radical treatment, you only need to know whether he has cancer or not and what kind of cancer. But if you want to do a precise ablation, you really have to know which area is the cancer and also the areas in which you have no cancer. So when you select your man, I think you are required to have a biopsy and imaging program which is established before. So the first thing is always to do an MRI before. MRI has some attributes which allow focal therapy. The first one is that you can see with good accuracy significant disease in the prostate. The other one is that in most of the time, you can overlook non-significant disease. So in this case, for example, you can see very well that the MRI can see the left lesion here by the right region, and you cannot see the small focus of Gleason 6, which is probably insignificant. Now, what you can always see here is that the MRI tends to underestimate volume. And again, as the previous speaker said, cancer has not round shape as we would like to see them. They are like a spider. So you have to account that there is some kind of ramifications that you cannot see on your screen when you look in an MRI. So if when you see your patient, you can see this man will be eligible, in my practice for focal therapy, then you have to choose what kind of biopsy you're going to do. And so this is a key decision because you need precise biopsy. So what is a precise biopsy, obviously? I think there are two ways of looking at this. The first one is to do random biopsy plus MRI transfusion biopsy. And the groups from Landmarks who are really expert in the technique, they show the results in consecutive men undergoing random plus fusion targeted biopsy in their center. And if you look at this graph, you can see that of those men who had an MRI visible lesion, so around 400 patients, those will be eligible for focal therapy, which was either targeted or quadrant or AMI ablation, were around 1/3 of the patient. In other words, if you see a patient in your clinic and he has a discrete lesion on MRI, there is around 1 of 3 chances that he is eligible for a focal therapy option. Now, obviously, the question is, if the patient is eligible on random and fusion biopsy, what happens if you take out the prostate and look whether he was really eligible? And so they did this And they saw that in these patients, so there were only 46 of the under 75. So the accuracy of this model was around 75%. In other words, you were correct 3 out of 4 times. Why you were not correct? There were 2 reasons. The first one was that the index lesion was much bigger and was crossing the midline, which means the patient was undertreated if he had focal therapy because he would have an EMI or a quadrant or a targeted ablation, or because the Gleason was higher than suspected before. There is one way to do even better, which means to do the same they did in PROMISE, and so to do a template biopsy of the prostate, you do a number of biopsy, and there you get a lot of precision in the index lesion, which is the most aggressive one, and also in the non-index lesion. So the groups from Heidelberg, they found in this series that if you combine both of them, you have a detection of 96% for the index lesion and of 92% of the every non-index lesion. These are not only significant cuts, but it's every lesion. So nothing is perfect, but it's really close to be perfect to select your patients for focal therapy. The key feature, I think, for focal therapy selection in my practice is when you go through the MRI visible lesion, when you go through precise biopsy, is the location of the index lesion and the extension of the targeted ablation we are planning. And obviously, you need to have a threshold of what you accept as an untreated area, which is positive on biopsy. And this is something which is this is open debate. You can say Gleason 6, 1 millimeter, 3 millimeters, 4, 5, non-visible lesion. There is no consensus about this, but we usually use 3 millimeters of Gleason 6 in a non-treated area is considered to be acceptable for focal therapy. Now, these are a few cases. So this is one patient which you can see he has a lesion in the peripheral part of the prostate. When we did the biopsy, we found only one lesion which was concordant. There was no biopsy positive on the other sides. And so this is, I think, a perfect candidate because the location is very easy. It's in the middle part of the prostate. It's far from the neurovascular bundles. It's far from the sphincter. There is no disease elsewhere. If the patients accept the focal therapy strategy, I think is a perfect case. These are the patient as a lesion which is in the anterior left side of the prostate, which you can see very well on T2 and the ADC maps. In this case, when we did the biopsy, we found also 2 millimeters of Gleason 6, which was on the other side. And so I think also this patient is a perfect candidate because, again, the location of the lesions allows to preserve a lot of tissue. And I think Gleason 6, 2 millimeters, you can observe with what we know today with the natural history of disease. Now, this patient is a different one because he has a big anterior lesion, which is close to the urethra. It's crossing the midline. And you cannot see here because there is no coronal or sagittal, but this lesion was really, really close to the sphincter. So I think this is really the worst candidate for focal therapy for many different reasons. The first one, you cannot have margins of ablation because you will treat the sphincter. The second one, these patients are more prone to have stenosis after treatment. The third one is that it's very difficult to control this anterior tumor, which really overruns of the prostate in the anterior part. This patient is a big lesion in the posterolateral side of the prostate. When we did the biopsy, we found bilateral. One side was visible, the other one was not visible. I think, again, in these cases with significant bilateral disease, and ones which is not visible, I think it's not a good candidate for focal therapy, at least as a standard option. Now, you not only have to select your patient, you also have to select your energy. And so the groups from Eric, they nicely show this in this night graph, in which you can see that depending on the location, we have different ablation modalities, which is not the topic today. But basically, in the anterior part, you have needle-based technologies. In the posterior part, I feel one of the best ones. And the apex is very difficult, and in their experience, radiotherapy by brachytherapy could be a good option. I think the other part of the other part of the eligibility process is the patient. You have a disease and you have a patient, and so you really have to counsel this patient, because there are things that we know, there are things we don't know. So if you want to look at what we use in the scientific community as eligibility criteria, I think the PART trial, which was done by the group from Oxford, is a good example of inclusion criteria for AMI ablation, basically what I've said till now. And so the randomized patient between radical prostatectomy and AMI ablation. And so what you can tell to your patient is that this is for sure, it is not subject to any kind of bias, because this is a randomized controlled trial. There's nothing best. So if you do a focal therapy or you do a radical prostatectomy, you can see the difference of 12 months. Urinary incontinence is almost not affected by focal, because they have the same prompts before and after focal. Obviously, it's affected by radical prostatectomy. At the same level, erectile function, it's much more affected. So I always say to my patients, you need to know what you want, because for sure, you're not getting the same. If you do radical prostatectomy or you do radiotherapy with other complications, you're not getting the same. So I think the functional value of the patients is really, really important. The third thing is that the patient should accept the follow-up and the unknowns of focal therapy. There are things we know as the preservation of erectile and continence after focal. There are things we don't know very well, which is the long-term outcomes after 5 years. And so patients who are for focal, they need a close follow-up. And when I regret my patients in which I did focal, these are people who they just didn't come to every follow-up, and I really don't know how they're doing till now after 2, 3, or 4 years. And the unknowns, we know very well what happens in the first years. There are a lot of reports in first, second, 3 years, 5 years, but 5 years is not enough in prostate cancer for the natural history. And we honestly don't know what happens after 7, 4, 8, or 9 years. So this is not something to say that it will not be very good, but something to say it's unknown, and the patient should commit to this.
Massimo, I'm sorry. Conclusion, perfect.
So in conclusion, I think focal therapy may be an option for many men, according to the PROMISE study. I think the patient selection is the key to success, and you really have to get imaging and biopsy right before embarking on focal therapy. I think you don't have to buy one energy and to adapt the energy to every patient, but you should really have the right energy for the right patient for the right location. And I really think the patients and the surgeon should commit to the strategy and believe in it. Thank you.
Thank you very much, Massimo. So we will have a few times to discuss at the end again. Let's move now to the last talk entitled "Why Does Focal Therapy Matter to the Patient?" Prompts by Dr. Befar Hidey. Dr. Befar Hidey is a urology surgeon at the Memorial Sloan Kettering Cancer Center in New York City, focusing on prostate cancer. He leads the active surveillance program for men with low prostate cancer. Additionally, he is examining the quality of life in men managed with active surveillance and outcomes after focal therapy. He has developed a standardized method to communicate risk with prostate cancer patients on active surveillance, and led a collaboration with Harvard Business School adapting negotiation theory in prostate cancer decision-making. Dr. Hidey is an international expert in prostate cancer and is a member of guidelines committees that determine the optimal prostate cancer management. So before, it's yours.
Very much. So it's a pleasure to be on this panel. Let's get through these slides. So my goal today is to, first of all, no disclosures for this talk, is really to discuss why do we measure patient-reported outcomes and apply them and adapt them in focal therapy. So this was the International Consortium of Health Outcomes Measures. It's a great publication. That's a website on the bottom for everyone to review. And they have a specific one for prostate cancer. But the goals are, when we measure patient-reported outcomes, is to learn about how our patients are doing, and subsequently use that information to improve performance. Our goal is ultimately to achieve superior outcomes. And with improvement, understanding our outcomes, that's how we can improve our outcomes. And as the healthcare system continues to shift, what we accomplish shouldn't be based on how many things we do, but how well we do them. And that can only be measured by asking patients themselves. So this was the landmark study that really launched patient-reported outcomes in prostate cancer. This was a comparative study of radiation therapy and prostatectomy. And what's key here is that the median outcome of quality of life measures was used over a period of time from baseline to 2 years. And despite initial thoughts that, patients who with one modality do much better than the other, when these patients were followed out to 2 years, these outcomes became very similar. And this was a landmark finding which changed how we evaluate and counsel patients. So when it comes to quality of life measures and focal therapy, what surveys should we focus on? This was a collaboration that I had the privilege to be a part of, in which we outlined as a consensus what the most important measures would be. So the conclusion was the Expanded Prostate Cancer Index Composite Survey, the International Prostate Symptom Score, the International Index of Erectile Function, the Male Sexual Health Questionnaire for Ejaculatory Dysfunction. So I'll go through each of these quickly. So the EPIC 26, it measures urinary function, sexual function, bowel function after treatment. This is a sample of some of those questions that patients would answer under the urinary function domain. The International Prostate Symptom Score measures urinary symptoms and bother. This would not be relevant post-prostatectomy, but is very relevant in patients who continue to have a prostate after radiation therapy or focal therapy. Again, the questionnaire is simple. It asks questions about obstructive and bothersome urinary symptoms with a final quality of life question. The IIEF measures sexual function across the domains of confidence, performance, satisfaction, erectile function domains. This is a sample of those questions, again, focusing on those domains. The IIF-6 specifically does include bother and symptoms that would be important when we talk about overall satisfaction with sexual intercourse. So here are some key factors. One, the questionnaire begins by asking over the past 4 weeks. So we have to be understanding, especially initially after treatments, that these questions may not be relevant to patients who may have not engaged in sexual intercourse due to the recovery of their treatments. The second, as was recommended by the National Consortium of Health Outcomes Measures, that the additional questions about the use of sexual medications or devices is recommended. So as these studies continue and as we write studies in focal therapy, it's important to collect this information. And as we talk about cutoffs for erectile function, the cutoff of a score of 26 or higher defines abstinence of erectile dysfunction. But what is a cutoff to define good erectile function? Firstly, terminology matters. So the choice is to use functional erections as defined by Dr. Mulhall in this publication, the Journal of Sexual Medicine. Second, the cutoff of 24 was used as this represented a score using the domain of satisfaction that represented across all measures a sensitivity and specificity to indicate these patients, although not above scores of 26, their satisfaction scores were considered good or above average. But is potency the only important sexual function domain for patients undergoing focal therapy? I would argue not. I think orgasm quality, ejaculation, and in some men there may be issues with chronic pain. So the Male Sexual Health Questionnaire for Ejaculatory Dysfunction remains an important additional survey for us to ask our patients. This is a sample of that questionnaire. So it's 4 questions, not only asking about the quality, but also the bother symptoms related to ejaculation. To give you some insights, this was a study that we presented at the American Urologic Association meeting of a pilot study in electroporation where we did a longitudinal study of ejaculation assessment. And what's very clear is when you look at quality of ejaculation across these measures from baseline to 12 months, there was a decrease in quality. But more importantly, this was associated with bother. The bother peaked at 3 months post-treatment, and then we see a normalization. And again, a slight increase most likely associated with the timing of biopsies. But again, this is something that matters to patients, both from the perspective of quality and symptomatic bother scores. So patient preferences regarding sexual function and expectations after focal therapy should be identified, and the discussion of outcomes must be expanded to sexual satisfaction. It's not just achieving an erection or question 2 that we often see cited in the literature. So I'll give you a little sample of what we're doing at our institution. We have everything automated. This is our system. And I tell patients or physicians when they want to start their own program that they need to start collecting data. So first, defining outcomes most relevant to your clinical practice. And you have to achieve agreement with among all faculty to collect data. And this must be done anonymously. For example, post-prostatectomy, we've identified multiple things that we think would be important for us to collect and understand. And then there's no ideal outcome, but instead the goal is to reduce variation among surgeons. And I think this is an example from positive surgical margins after prostatectomy across multiple institutions. And we may not know what the right answer is because a patient with high-risk disease may not have the same positive surgical margin incidence as someone with low-risk disease, but the variation across disease types should be limited, which should be the goal of all patient-reported outcome measure assessments. And then as this information is fed back to physicians, we should allow surgeons to adjust for clinical characteristics and provide feedback with real-time updates. For us, we collect information with emails and measures sent to patients every 3 months after their treatments. And then when this information is collected, adjusted in analyses and fed back to physicians, we're allowed to adjust within what we're looking for, whether we want to look at only in high-risk patients or whether we want to look at 1-year data or 3-year data. This has all been automated. And the lack of communication of outcomes between patients and physicians leads to misperceptions of actual outcomes. And this is important. What we sometimes hear from patients and what the patient's actually trying to communicate may be different. We actually ask that question. So since starting the program here at Memorial, where we feedback outcomes to physicians, we found that feedback of outcomes improves the agreement of physician perception of outcomes of patient-reported outcomes. So this is the correlation in urinary continence post-prostatectomy in patients. As you can see, the agreement percentage increased after the implementation of the Amplio program, which is the patient-reported outcome program in our institution. And also patient outcomes help researchers understand trade-offs between decisions such as treatment versus active surveillance. This was a study in which we looked at the recovery of erectile function after surgery in a 55-year-old patient. As you would expect, there will be a decrease in the IF6 score and then an increase in recovery over time. But the question always is, what if I delay surgery? Is there a benefit? Well, we can then mark and evaluate a patient at age 60 who underwent surgery, median outcome of thousands of patient-reported outcomes in those men, and graph out what that recovery would look like. And then to assess between those 5 years of the patient gain, whether they underwent focal therapy or active surveillance, you can look at the baseline function of patients that you've collected over years to represent a true population-based decrease in erectile function without treatment. We did that. And when we looked at the area under curve, it was very clear that delaying treatment in a 55-year-old by just 5 years over a 10-year period improves the overall erectile function by 2 points, which is equivalent that was used in the trials for sildenafil and Viagra to look at for approval by the FDA for an aid for erectile function. So a significant difference. So finally, when you look at this, was a recent study we published or we presented at the AUA when we did a systematic review of focal therapy studies from 2000 and 2019, looking at patient-reported outcomes measured. And the methods used to report data we found were very varied. So across thermal and non-thermal types of focal therapy, it was clear that the outcomes being reported, whether it was different surveys, whether it was different questions within the surveys, whether they were even collected or the time periods varied significantly. And these were studies that were collected based on the quality and methodology of number of patients, randomized controlled trials. So not every retrospective study was included. And even in those studies that we were deemed as high quality, we noted this variation. So standardization does matter. And I think the initial work to bring all those surveys together helped. So in conclusion, measuring patient outcomes is vital to improve clinical care and manage patient expectations after treatment. Helps us learn the impact of novel focal therapy interventions on patient outcomes. It improves patient care by reducing variation among physicians. It guides physician and patient decision-making. And finally, a key is standardizing methods to measure and report data is key for us to understand differences and improve across institutions. Thank you very much.
Thank you very much, Before. Thank you, you all three, for your wonderful talks. So we have 13 minutes for discussion. So I have a question. My first question is for Professor Ward. Professor Ward, what do you recommend to a young urologist who want to start focal therapy? You explained that there are different ways of doing focal treatment. What is your ideal treatment option? Quadrant, AMI ablation, acoustic, subtotal ablation? For example, a patient with a 1 centimeter right side base posterior lesion, Gleason, or ISUP2. What do you recommend?
Well, I think what I was trying to point out in the in my talk is that you can apply different templates for your patient. This is truly, as you coined, this is a very individualized treatment therapy. And so it can become an a la carte, and there's no one template that is appropriate for all patients. What you have to consider is, as I was trying to explain, is what your goals of therapy are. When you look at, like Befar's last talk, at what your expectations for functional outcomes are, when you look at, as was described by Massimo, in what your cancer outcomes are and your expectations on whether you're going to allow small volumes of low-grade tumors or not, that's going to define what you use as your template for that particular patient. Even location of tumor, as one of the examples was, a tumor towards the apex is going to have a much different template that you're going to consider, or a targeted treatment that you're going to consider, than one maybe towards the base and anterior. So I don't think you can get locked into a single template for all patients. And it's good to know that all of these variations are out there so that you can personalize your therapy.
And how do you find the lesion when you treat? Because this is our main problem, how to find the lesion. So we have an MRI, we have a biopsy, we usually have a concordant disease, but how do you, I mean, in your experience, find the lesion during the treatment?
So in my experience, since we tend to do more of a template and are willing to sacrifice more normal tissue than others are, we will use the information that we get both from a targeted biopsy, because most of the patients that we're considering for focal therapy do have some lesion that is visible on MRI, as well as the information that we get from the random biopsy. So we'll include regions of the prostate if they have positive cancer, even if we don't see an area on the MRI. So we use a combination of both the targeted biopsy and the standard biopsy information. Now, we do use the Artemis device. You know, there's many different means of performing MRI, ultrasound fusion guided biopsy. We're also using the Artemis device to help us in placing the cryo needles into the same location that we obtained the biopsy from. So these are, there can be modifications for each individual patient to account for that.
Okay, thank you. I have a question for Massimo. Massimo, how do you manage a patient with a lesion Pirates 3? I mean, in this patient selection, how do you manage this kind of patient? Do the systematic biopsy? And in case of lesion, how do you offer to the patient?
I think Pirates 3, obviously, the radiologist is not really helpful because he just doesn't, he or she doesn't know. So I think you need another measure to look at whether this patient is very likely to have a prostate cancer or not. So in my practice, we use the PSA density. And so if you look at the study, if you have a very low PSA density, we don't biopsy these patients. and we follow them with PSA and another MRI, depending by PSA kinetics. If the PSA density is high, then in those cases we biopsy them.
Okay. How do you biopsy the patient? So do you do the transperineal, transrectal? What is for focal therapy the ideal biopsy selection for patient? Transrectal, transperineal?
I'm really committed to transperineal. Yeah. For different reasons. I mean, the first one, I think you don't have any anatomical issue, and you can really biopsy the prostate wherever you want. I mean, the anterior part, the basal part, the apical part. I think you can have a nice diagram of what you're doing afterwards. Nice, I couldn't show here, but you have a nice model of the prostate. And again, in all the parts of the prostate, you obviously have much less infection problems afterwards. And I mean, you don't have the problems you have with transrectal, which means you know, the deflection of the needles, the problem with the fusion. I think the transperineal for me is much more immediate. So in our series now, we do 90% of our cases with transperineal.
Okay, and you say that the tumor is a spider, so we agree. So how do you biopsy the spider? Do you do 2-3 targets and biopsy around, or just inside the lesion? On how do you biopsy the, in order, because the problem is to, as you say, or I don't know who say that, we have to find the right lesion for the right treatment for the right blah blah. So how do you target the lesion?
I mean, I will reply to your question, but if I respond, but the first thing to imagine is that obviously the bigger the lesion, the less needles you need, because you're not going to miss it. But the smaller the lesion, the more needles you need, because you can have fusion problems, you can have problems in your targeting or deviation of the needles. So in our practice, we do 3 or 4 lesion in 3 or 4 targeted biopsy in the core of the lesions. We don't use to do you know, around the lesion the extra biopsy, and the reason for that, I think, it's very, very difficult to know, you know, to reconstruct in 3-dimensional how far you were from the core of the lesion. And I think if you're going to focal, you need to assume you have margins. And so in our practice, we always take one centimeters of margins. We assume that the spider is covered by our margin of tissue or normal tissue around this. But what we do is that we always do the model from Barzell, which means to biopsy all the prostate in all the areas. We accept the margins, but we don't accept, you know, other areas which are no neighbors to target index lesion to be a focal therapy option for this patient.
I have a question for Var. I remember I was talking to you and John Coleman about a year ago, and you know, I practice in Durham, and I think maybe some of the folks are more simple-minded, but it became apparent to me that many of the city dwellers are really focused on things that urologists haven't considered, such as ejaculation, ejaculatory volume, things like that. And traditionally, our outcomes have been continence, maybe how many pads, can you get an erection with or without Viagra? So where do you think the field is going when we start really delving into ejaculatory satisfaction, quality, amount of ejaculation? And at the same time, it's important to record these outcomes, but it's hard to have databases with really hundreds of variables. So what do you think is the future and the sweet spot for this?
Great question. I mean, 2 things to unpack there. One is, of course, survey fatigue is very important. So we have to be very careful how many questions we ask patients. And I think surveys are doing better and better jobs of being smart. So what we've implemented is, if you, for example, answer, I'm not having erections, you're not going to answer 6 more questions about the quality of your erections. The survey stops right there. So smart and AI-driven questionnaires is key, and also limiting the questions. The second part of that's important. I think it matters what we're comparing it to, where patients begin. I've become more and more aware that focal therapy represents the next step after active surveillance for many patients. So the comparative group remains probably active surveillance for many of these patients, and that's what they know, whether that's where they start or where they're trying to decide between. And if we talk about delay in treatment, it's a delay from active surveillance to radical therapy. So when a patient sees themselves without treatment, then their quality of life represents multiple facets. So it could be quality of sexual intercourse, it could be pain, it could be not undergoing biopsies. So there's so many factors that I think will now be important when we compare really to non-treatment. When you compare to radical treatment, of course, asking about ejaculation is irrelevant because one group will not have semen or ejaculation. Perhaps orgasm scores will be important in that group. So I think the comparative group, and the direction I'm going mostly, as you can see, is asking questions that will be relevant for both patient care, but also clinical trial assessment for, future ability to bring focal therapy into guidelines if feasible.
Before I have a question, what about anxiety? We know that the patients who are diagnosed with prostate cancer are very anxious, and they are always, they have to face a great dilemma to be treated or not. And sometimes when they choose focal therapy, we explain to them that this is I would say an investigational treatment. So maybe we had anxiety. So how do you measure? I know that for prostate cancer in your institution, you developed the MAX-PC questionnaire. What about focal therapy?
So the MAX-PC is a great anxiety score if you want to collect data on prostate cancer. So that's a great point because PSA is part of that and asking PSA. But your bigger, broader question is, how do we prepare patients for focal therapy? And some of my work in active surveillance, which I think is very similar in preparing someone to begin an active surveillance, I think goes hand in hand. So quickly, I think you have to normalize the process for patients, meaning you have to understand and feed them right from the beginning what our expectations are. You're going to go through biopsies. Biopsies are not comfortable. You're going to actually tell me in 3 years that you don't want a biopsy. I'm telling you now that's what you're going to tell me. So normalizing the process, telling patients that you're not the only one who doesn't want to have a biopsy in 3 years. Many don't, but this is why it's important.
I'd like to thank everyone. It's a great discussion. I'd like to thank our sponsor, Wasatch Medical, again for this program. Our next discussion will be robotic prostatectomy, moderated by Ash Tiwari, and you can see the speakers. I'd like to encourage everyone who isn't already a member to join the Endourological Society and the Focal Therapy Society. Your membership dues provide you with many benefits, including online access to the Journal of Endourology, etc. And finally, we're hoping to have an in-person meeting at the WCET 2021, September 23rd through 25th in Hamburg, Germany. Thank you for your attention.